Thank you so much, Jen, and thank you so much to Payne BC for the very kind invitation to speak at this webinar today. I'm very fond of the work that Payne BC does. I've enjoyed many past collaborations with Payne BC, with Maria Hudspeth and Catherine Sutton as well. So again, nice to be able to share at least this virtual space with you all again, and also thank you to everyone online for joining today. So I'm a bioethicist. And what that means is I study sort of ethical issues related to health and healthcare. I'm a bioethicist at the Center for Addiction and Mental Health in Toronto, which is a large mental health hospital where I provide clinical ethics consultation and organizational ethics consultation, as well as a scientist doing research there and at the University of Toronto, where I'm appointed as a faculty member. And my research over the last few years has focused broadly on three dimensions: on ethics of mental health, substance use, and chronic pain, where they sort of occur independently, but also where the three occur at the intersection, which I know many folks on this audience know very well. With my talk today, I intend to be a bit provocative. This is a very challenging topic and an important topic, and I think one that I'm hoping to generate some really great discussion. So I look forward to your thoughts during the Q&A. In terms of my acknowledgements or disclosures, I receive funding from the Canadian Institutes of Health Research, as well as a collaborative academic practice grant program at the University Health Network in Toronto for grants related to ethics of chronic pain and substance use, and I have no other financial conflicts of interest. I want to acknowledge as well my colleague, Dr. Suze Burkout. Some of the content that I'm going to be discussing and presenting here today is based on a forthcoming chapter that we have in the Routledge Handbook on Feminist Bioethics. It's called "What Does It Mean to Be a Brain Disease? Feminist Bioethics Perspectives on Chronic Pain, Addiction, and Neurotechnologies." I work at the Center for Addiction and Mental Health in Toronto. And before I begin today, I want to just provide a land acknowledgement from CAMH. So the Center for Addiction and Mental Health is called CAMH. It's situated on the lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. The site of CAMH appears in colonial records as the council grounds of the Mississaugas of the New Credit. Toronto, where I am situated, is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, share the land, and protect it for future generations. And so I know we're sharing the space again virtually today, so I encourage you, for wherever you are in the world, to think about the ancestral lands in which you're situated on, and which you're working on, and which you're benefiting from. So for our outline for the presentation today, I'm going to first talk about what's called the neuroculture. Then I'll talk a bit about the rise of the brain disease models in both addiction and chronic pain. And I'm going to talk a bit about their ethical strengths as well as their ethical vulnerabilities. And then we'll conclude and hopefully have some time for discussion. So we are living in a neuroculture. And what this means is that we are increasingly understanding ourselves and who we are as human beings in terms of our brains. So we increasingly understand our identities in terms of our brains. We increasingly use neurocentric or neuroscientific type language to describe our experiences. So many people may have said, wow, I just had a great adrenaline rush from going on that run. Or, clicking all those likes or getting likes on Twitter or Instagram or Facebook or whatever is causing a rush of dopamine in my brain. So this folk neuroscience is in many ways reflective of this modern neuroculture in which we sit. And the brain, in many ways, has become the equivalent of our modern soul, really. So for ages and ages and ages in many different civilizations across the earth, the soul was sort of central to our identity, our self. And many, for a long time, believed the soul was located in the heart. But perhaps now we might think of the soul, if there is one, or a material soul, as located in our brains. It is, again, the very seat of our identity. And we do see the neuroculture in our everyday life in many different ways, not just in terms of the language that we use to describe ourselves, um, but in many, let's say, popular publications, advertisements, research funding priorities. So I'll just put a few different headlines or sort of book examples and other examples here on the slide just for you to look at of how we do have the neuroculture in our everyday life. Some folks on the line, on the call, on the line, on the internet might be familiar with the book that came out in 1993 called Listening to Prozac by the psychiatrist Peter Kramer. And Kramer explores how Prozac, the antidepressant, changed the brain of his patients and ultimately, what he argues, their personalities. And so he raised a very fundamental ethics question about authenticity. So who is the real person? The medicated person or the unmedicated person? Or is it both the same? Um, you know, Promoting mental illness within a brain disease framework is thought to as a way to combat the stigma of mental illness. I'm going to talk a bit about that. I will talk about that a little bit later as it relates to both substance use and chronic pain. But somehow having a biological representation of mental illness through seeing it through the brain will combat stigma. There's on the second to the left on the top row of examples there. Some folks might remember this ad campaign, this anti-drug campaign. The person holding the egg, saying, the egg representing your brain, and then the frying pan being drugs, and then the fried egg being this is your brain on drugs, symbolizing or at least trying to generate some fear tactics in what might happen to your brain and perhaps then by extension to you should one consume substances. So this was a fear-based campaign that was very, very popular in the cultural imagination, at least in North America. If you on the left-hand side of your screen, in the bottom left-hand corner, there's a picture that I snapped in the subway in Boston a number of years ago. Unfortunately, I wasn't able to get a good picture of it, but basically what it says is, it says thinking or drinking. What will it be for your kid? And below it's juxtaposed of two images, presumably functional magnetic resonance imaging images of a brain, one with some red color in it and one that is absence of red color. And so the person viewing it is supposed to presume that they know how to read a functional brain imaging scan, a functional MRI scan, and know sort of what that represents. But intuitively to the reader, again, it's like, oh, which brain do I have, or which brain does my kid have if they drink? Which one is the bad or the abnormal brain? Which is the different brain? Which is the good brain? Which is the brain that I want my kid to have? And I'm going to touch on some of these really important ethics themes a bit later on. So, altogether, this is coming down to the idea of neuroessentialism, or neuroreductionism, which means, the idea that we are our brains. And I'm not going to say that we are or we're not. I'll also leave that up to you to think about. But this is something that's very reflective of our modern culture these days. Where this comes across in particular is in addiction. And substance use and the concept of addiction in particular. So this image that you see on your screen here is by William Horgath, and it's a print called Gin Lane. And it came out in 1751. And there's a lot of very interesting imagery and symbolism in this image. So people have used drugs since, or various intoxicating substances, or psychoactive substances, I should say, since millennia. People use drugs. Human beings use drugs. Mammals use substances. We all use some form of substance, whether it's alcohol or caffeine or an opioid or an opiate, or whether it's in the form of a medication or it's in the form of something that's, procured in non-regulated spaces or elsewhere, right? So and they've been categorized in different ways over history. The idea of what substance use is has held different meanings over time. But for a long time, substance use was not as highly stigmatized. And I'm not going to go into a whole history of substance use in the modern West and its associations with morality. But what we do know is that around the 18th century, substance use started to become somewhat of a problem. And there was associations of substance use, or at least in the cultural imagination, in terms of productivity and contributing sort of economic productivity to society. And so what we see in this picture is various images about, so gin lane, gin being alcohol, that you have, people, and these people sort of, the image directly in front of you is a picture of presumably a mother, and her baby is falling off the side. There's a very strong gendered component to moral judgments about substance use and what means a good mother. So clearly, this is a bad mother who's, neglecting her child, and his child is falling off. You see other people who, are chewing on dog bones or sitting with other animals. There's general mayhem, right? So this is associated again with poverty and sort of stigmatized ideas about people who were amongst the lower class and various motivations that they had in terms of consuming alcohol and what that meant for their moral character. So in many ways, addiction and alcohol use in particular, and was starting to be seen as a disease of the will or a problem of willpower. Someone cannot control their will or their ability to use substances, and alcohol in this case in particular, and that was seen as a moral wrong or something that was a wrong to do. And someone who had a very strong moral character was someone who was able to resist using substances, because it ultimately, at least on this view, led to sort of sort of aspects of society which were highly stigmatized and looked down upon. And this idea as addiction as a moral problem, has lasted centuries and very much right up until this day. However, as addiction research still started to develop and scientific research in addiction developed, people started to use more sophisticated tools and experimental methods and develop a greater understanding of, let's say, the biological contributions of addiction, and said, you know what? If we could only understand addiction as a problem of biology, maybe that would reduce its stigma. So in 1997, there was a very well-known article that came out in Science by Alan Leshner, who was then the director of the National Institutes of Drug Abuse in the United States, and he had a very, very powerful article called "Addiction is a Brain Disease and It Matters." Now, Leshner wasn't the first one to talk about addiction as a brain disease, but he definitely popularized the term. And actually, so the idea of a disease model of addiction has roots going back even to the 18th century in a physician named Benjamin Rush and others, who considered inebriety, or sort of alcohol intoxication, as a progressive disease that gave rise to a loss of control over drinking. But so, Leshner's not the first one to talk really about this, but he definitely popularized it. And the goal of brain disease models of addiction, or advancing such models of addiction, is actually a very compassionate one. Because of the stigma, discrimination, and prejudice that many people do experience as a result of their substance use, the idea, again, is that, if somehow we could, consider addiction as a brain disease, maybe people wouldn't be blamed for their use. Maybe people would be treated more compassionately. Maybe we would have less punitive drug laws and drug policies. Maybe the war on drugs wouldn't cause harm because this is a legitimate medical illness, and not someone's fault or their choice. And this idea was picked up later by Nora Volkov and Lee in a well-known paper in 2004, when Nora Volkov is actually the current director of NIDA in the US, and where they likened the statement that they have here to addiction to other medical diseases. So in this case, in heart disease, to make it a disease like any other. And they say, and these are my emphasis in the quotes, drug addiction is a disease of the brain and the associated abnormal behavior is the result of dysfunctional brain tissue, just as cardiac insufficiency is a disease of the heart, and abnormal blood circulation is the result of dysfunction of myocardial tissue. So through using language such as disease, the language of that neural dysfunction produced by drugs is framed in terms of brain pathology. So advocates of this view argue that modeling language in terms of brain disease makes room for individuals living with an addiction to receive the same level of compassion and access to healthcare services as individuals that are living with other medical diseases, and promotes, ideally, enlightened social and legal policies. And in addition, framing addiction as a brain disease, akin to other sort of medical diseases, is believed to combat stigma, which is as I've mentioned, endemic to substance use in people who use drugs. And so really there was sort of two different promises that came out of the brain disease model. So first is what I'm calling the epistemic, or actually I'm calling, and others have also called, the epistemic promise. And so this is, is, as Neuroculture says, in a movie actually produced by NIDA on addiction, as a drug addiction is psychological or physical disease, it's a disease of the brain. That disease translates into abnormal behavior. But also, and primarily, there's also the therapeutic promise. And this comes from Leschner's article. And this is critical also, as I'll talk a bit about later, to understanding recent conceptions of chronic pain as a brain disease. So understanding that addiction is at its core a consequence of fundamental changes in brain function means that a major goal of treatment must be to reverse or to compensate for those brain changes. Elucidation of the biology underlying the metaphorical switch is key to the development of more effective treatments, particularly anti-addiction medications. So again, addiction is located in the brain in this metaphorical switch that is believed sort of to turn on when addiction happens, and that our interventions for addiction, because there really hasn't been that many good treatments. There have been treatments over the years, but really, perhaps not on the broad scale very effective ones. So Leschner is saying, what, we need to, if we focus it as addiction as a brain disease, we could develop more targeted brain-based interventions. And mental illness also has been discussed in terms of a brain disease as well. And I won't spend too much time here, but just the basic idea is that so the article on your left came out in 2010, so already 11 years ago. But what the authors did is they examined responses to the mental health module of both the 1996 and the 2006 General Social Survey in the U.S. And this was describing individuals who met the DSM-4 criteria for schizophrenia, major depression, and then what was called alcohol dependence, now alcohol use disorder. They wanted to know, first and foremost, whether or not the public, first and foremost, embraces a neurobiological understanding of mental illness, and two, endorses treatment from providers, including psychiatrists, and three, reports community acceptance or rejection of people with these disorders. And so they found that in 1996, 54% of respondents attributed depression to neurobiological causes. And in 2006, this rose to 67% of participants attributed depression to neurobiological causes. They also found that neurobiological causes of depression increased the likelihood of support for treatment, but interestingly did not affect perceptions of stigma. And it actually, in some cases, endorsing a neurobiological understanding of neurobiological understanding of depression actually increased certain aspects of stigma, such as fear and social distance. And so these findings are actually consistent with many other studies which suggest that biological explanations of mental illness, in fact, and ironically and unintentionally increase certain aspects of stigma. So this has a completely counterintuitive notion. And on the right, there's a meta-analysis by Lohman and Haslam that looked at how neuroscientific explanations and the stigma of mental disorders, and they actually found that there are, again, very mixed responses. In some cases, certain aspects of mental illness, such as blame or blame for the mental illness, went down, but other aspects related to fear and social distance and other dimensions of stigma in fact increased when mental illness was described in neuroscientific terms. So what we're starting to see here is potential unintended consequences, at least at the public level, of describing mental illness in neuroscientific terms. My colleagues in Australia, Wayne Hall, Adrian Carter, and Cynthia Forlini, published an article a few years ago in the Lancet Psychiatry, where they took a very critical examination of some of the evidence of the brain disease model of addiction and asked, has it delivered on its promises? And I am afraid to say this is somewhat of a rhetorical question, and because, in fact, what they demonstrate is no. Brain disease models of addiction, at least since Leshner came out with that article in '97, have not necessarily translated into improved treatments for addiction, have not necessarily led to more compassionate policy responses to treating substance use issues. In fact, many people are still incarcerated at very high rates, at least in the United States, for, let's say, drug offenses like possession of cannabis. Again, disproportionately affecting racialized, particularly black populations. So, is there evidence that the brain disease model of addiction exists? And they suggest no. And has it, has it achieved sort of this epistemic and therapeutic promise? And they also argue that no. And in fact, it's sort of potentially ethically worrisome given its increase on in certain aspects of stigma. So now I want to return to, or I want to begin actually discussing chronic pain. So, chronic pain, again, like substance use, has been, around since the beginning of time. Chronic pain has held various different meanings and definitions and interpretations over the course of history, cross-culturally as well. And so, but one thing that has been sort of associated with chronic pain, again, I'm not going to go through a whole long history of pain here, and there's some excellent tomes that look exactly at this very question. But one thing we do know, and is probably very familiar and close to a lot of folks on this call today, is that chronic pain is also very highly stigmatized. People are accused of being lazy, of faking, of exaggerating, of catastrophizing, right? These are all very stigmatizing labels that have applied to people who are living with chronic pain. And as a result, people have had their suffering intensified. And also chronic pain has been interesting at least since the rise of biomedicine in the 18th century, because chronic pain, by definition, is an invisible and subjective condition. It is, pain is what the person says it is. And this causes a lot of tension and frustration in contemporary biomedical contexts that are very focused on objective and quantifiable indicators of pathology. So, I'm sure it's, everyone on this call knows the relationship between, let's say, an objective indicator on an MRI or an X-ray does not necessarily correlate with the intensity or the experience of pain by the person. Sometimes there may be no evidence of pathology, and the person's pain and associated suffering is intolerable. So this has presented a huge challenge for medicine, for healthcare, and for the biomedical sciences. And this has encouraged over the years many different efforts in conceptualizing chronic pain. I'm not going to spend time on all of these different models that I have on the screen here, but one thing you can see is, in some ways how pain has become very sort of neurocentric, and or models at least neurocentric in its approach and understanding how the brain works, but also with biopsychosocial models, so biological factors, psychological factors, social factors. Some have added spiritual factors, even systemic factors, and then increasingly advances in the neuroscience of chronic pain. That has contributed to understanding the neurobiological, neurophysiological aspects of chronic pain have made huge strides in this way. And actually, what's interesting too about understanding the neurobiological understandings of chronic pain, and people say, well, yes, this is really important, but we have to understand the social dimensions. We have to understand the psychological and the sort of the broader structural dimensions as well of pain. And of course we do. But there has been some interesting literature as well on biopsychosocial models in general, saying, we do know that biopsychosocial models are sort of prominent pain management, and we know that multimodal approaches to chronic pain that addresses both, psychological and, massage, mindfulness, acupuncture, et cetera, et cetera, et cetera. Cognitive behavioral therapy. These multimodal approaches are physio. Are sort of the best at helping to manage chronic pain. But some have actually criticized biopsychosocial models as being actually very focused on the bio part, or emphasizing the bio, and minimizing the potential intersections of other factors. So, as chronic pain, again, as an individual subjective condition that's often refractory to objective assessment, this has motivated in part some researchers, particularly in the neurosciences, to use very sort of advanced tools such as brain imaging tools such as functional magnetic resonance imaging, to understand sort of what's going on inside our brains when people experience pain or experience chronic pain. And this has also led to what's been called by some to the pain imaging revolution, but also start to question, whether or not chronic pain should also be considered a brain disease, much for the same reasons and in the very same way as people are motivated to call addiction a brain disease. Again, to objectify and quantify, a subjective condition, to improve treatments, to lead to more compassionate care, and particularly to reduce stigma. So in this one article, from Borsuk and colleagues, what they conclude is that the major insight that emerged from neuroimaging studies is that chronic pain is a disease of the brain, and thus all therapeutic modalities will need to take this into consideration. So they don't go into specifics about what exactly it means, but this quote actually in many ways is reflective of what we've seen in addiction around the therapeutic promise, and their specific referencing of chronic pain here as being a disease of the brain. Similarly, Irene Tracy and Catherine Bushnell, they take a more cautious approach than Borsuk and colleagues, but they also say, imaging studies have shown that chronic pain is associated with functional, structural, and chemical changes in the brain, thus putting it into the realm of a disease state. They, again, are more cautious about this, but they're questioning, are we actually seeing something based on our increasing understanding of brain imaging, that perhaps chronic pain should also be a disease. We see advocates and leading pain advocates who are doing remarkable work, like Dr. Sean Mackey, a leading figure, an important advocate and clinician and researcher in pain. He tweeted this, a little over a year ago. I'll sort of work backwards in this tweet here. He says, chronic pain is real. Absolutely, chronic pain is real. Chronic pain is more prevalent than cancer, diabetes, and heart disease combined. That is absolutely true. Chronic pain is a disease. Perhaps, I'm not sure yet. So what I'm hoping we can do today for the remainder part of this presentation is really take a hard look at this and take a critical and thoughtful look at, what are the possible implications of considering chronic pain as a brain disease. And we see this in some leading publications, right? The landmark report, Relieving Pain in America, put out by the Institute of Medicine, even the National Academies of Medicine say some types of chronic pain are diseases in their own right. The Canadian Pain Task Force, again, said chronic pain is a disease in its own right. We saw, recently in the ICD-11, a really important statement in terms of the history of chronic pain that this quote here is from the International Association for the Study of Pain, so the leading international pain association in the world, said the ICD-11 will be the first to include chronic pain. Chronic primary pain represents a disease in itself. So this is quite remarkable. Now, of note, they're not mentioning brain disease specifically, they're mentioning disease, but again, many of these disease framings of pain are based in advances in the neuroscience of understanding of chronic pain. So is there a difference between brain disease framings and disease framings generally? I'm not sure, but we are seeing an increase of framing chronic pain as a brain disease, again, for really important reasons. To reduce suffering, improve treatments, potentially improve access to treatments, and importantly, reduce the stigma that is so endemic to chronic pain. But not everyone in the pain community actually agrees with this disease framing. And so there is skepticism within the pain community where people are really questioning, do we have enough evidence, for example, to consider chronic pain as a disease or even a brain disease? Are we ready yet based on where we are with our neuroimaging evidence to make that leap? So people have questioned that, and some have actually, including this editorial by Sullivan and colleagues, with some leaders in pain management saying, hey, like, what are the potential clinical implications that this might have for people who are living with pain? So now I'm going to take a look at some of the sort of ethical strengths and vulnerabilities of calling chronic pain a brain disease, looking from what we've known now from the brain disease model of addiction. And maybe there's some ethics lessons that we can apply here, or we can at least think about. The first point I actually want to make is that the brain model, or what might be considered a brain model of addiction or chronic pain. So this is describing pain in neurobiological terms, does not necessarily equal a brain disease or the brain disease model of addiction or chronic pain. And this is a very nuanced, but I think important distinction to make. So, and this is actually important from an ethics perspective. So, what adding the label of disease does, it's what we call in ethics a normative exercise. So what a normative exercise is suggesting what we ought to do. And also from a sociological perspective, when the process of disease making or disease creation, or developing criteria for disease is inherently sort of a social and political process. We know that definitions and diagnoses, for example, for mental illness, have changed throughout history and over time and are different across cultures. We know that they differ depending on what version of the DSM, the Diagnostic and Statistic Manual of Mental Disorders, you are working with. But inherently, sort of into our biomedical or medicalized understanding of disease, is that calling something a disease is a marker of deviance. It's saying that something is actually abnormal. So when we say that something is diseased, it's not necessarily seen in a perhaps positive way. So we are saying that this person who has this set of criteria or meets this criteria for, let's say, biological reasons is abnormal from the quote unquote average or normal in certain ways. So there's an inherent marker of deviance here. And so when I think there's something that's important happening ethically that we need to think about when we move from the brain model of addiction or chronic pain to a disease model. So what are some of the ethical strengths here of considering a chronic pain as a brain disease? Well, chronic pain is very much contested, is misunderstood. It's something that's typically not taught in medical schools or health professions education. And I should say this. I just came off this week of lecturing almost 1,200 medical students and physician assistants at the University of Toronto on ethical decision making in chronic pain as part of their pain curriculum. So there is some progress and there is advances in certain places. But by and large, veterinarian school students get much more attention to pain than health professions or medical students do. And so this is in part, it medicalizes a very contested condition that has been historically. And also it provides some legitimacy. So saying something is a disease gives it medical legitimacy. It gives it something material that people can point to, say, hey, yes, I have something that can be explained by the medical profession. And what we know from evidence from the mental health literature and elsewhere is that having something that's medicalized or legitimized in this way can give a lot of comfort to people, to patients, to people living with pain, to their family members, saying, hey, we have something that can be explained, and now there's something that we can treat, right? Because if we can't explain it, then we might not be able to treat it, or we don't know what it is. So there's potential benefits there. So these are one ethical strength. If we can, medicalize and legitimize chronic pain as a disease or as a brain disease, this may actually lead to increased research and treatment funding and resources. So, chronic pain programs, as many of you on the call know, are grossly underfunded. there is huge inequities in access to pain management. I know that in some cases there can be years-long wait lists to access pain treatment programs in some hospitals, which are often located in major urban centers. So there could be huge geographic inequities, right? So, if we medicalize something and call something a disease, this actually may lead to more research into the condition, as well as improved treatment and funding. I mean, I think COVID is a remarkable example of this. We had this novel coronavirus, and then there's huge amounts of money flooded into vaccine research. And the most remarkable thing of developing at least 4 approved vaccines in Canada to treat COVID, treat the SARS-CoV-2 virus, just so that, I mean, there's potential benefits here for pain. So, who knows? And, similar to addiction as well, maybe this will lead to more compassionate treatment and policy responses. Maybe this increasing recognition of pain as a disease, chronic pain or persistent pain as a disease, has led to this creation of the Canadian Pain Task Force and its reports. This is on the federal radar. Maybe this will lead to more compassionate policy responses for people in pain, which may include more compassionate insurance policies or so-called disability policies as well. That's more equitable. That is more compassionate. And so, these are all very much potential and very important benefits that can come from increased medicalization and disease or potentially brain disease framings of chronic pain. But if the brain is truly the seat of the modern soul, I think there's other things we need to think about. So the image that you have on your screen here comes from a wonderful book by the anthropologist named Joseph Dumet, who asked this very question: is it me or is it my brain? And his book, Picturing Personhood, looks at how brains are represented in biomedical, in brain scans for depression. And so what Dumet suggests, and this is actually similar to the image that I had showed earlier on in the presentation about, thinking or drinking, what will it be for your kid, And so, most people cannot read this SPECT image. Most people do not know what these various colors mean, but there's an intuitive appeal to seeing the brain. Also, there's this sort of unmarked universality here. And, typically in brain imaging research, what you see here is, an average of many different brains, not just one brain. But what it invites the observer to ask is this me or my brain? Which brain do I have? Which do I belong to? And, more importantly, am I normal? So because the brain is so close to our identity, it's not just something that we might live with, but it is inherently us. And especially if something like pain and addiction are so highly stigmatized, if we have a diseased brain, what does that say about us as people? So this gets back into the idea of neuroessentialism, so that you are your brain. And you can see in this image the various categories that this applies to. So, neuroimaging data has been used, particularly a persuasive tool in presenting, the addicted brain, as a certain kind, or what's called a natural kind, and reinforcing this certain kind of neuroessentialism. So, neuroessentialism really is the idea that the essence of identity can be reduced to the brain. So in other words, you are your brain. And so imaging data, I think, be used in this way, or at least presented in this way, has been very successful in rendering pathological entities and constructing different kinds of brains that stand in opposition to so-called normals. So you can see on this image on the top, you have these categories of alcoholic, obese, cocaine dependent, and they're juxtaposed against these so-called normals, right? So, so appealing to brain images in this way, or neuroscience, facilitates justifying certain claims to pathology that naturalizes these difference between, let's say, the person who uses drugs and a normal, or the person living with pain and someone who's normal. So in this view, addiction, and we might think of similarly for chronic pain, as a kind of neurobiological otherness. So this may encourage an us-them distinction, which we know is sort of essential to stigma. So, but what is, perhaps I think more troubling for me is that, despite sort of the intent here of using biology or science as moral neutrality, neurobiological explanations of addiction, at least, and potentially this could happen for chronic pain, sort of continue to reflect and reproduce, a pathological figure of the person who uses drugs, whose life has been destroyed by drugs, right? So, might the same thing happen with pain? Someone whose life has, been destroyed by pain, and there's no sort of other sort of positive aspects or strength aspects, and so this may lead to increased stigma and social distance, as we've seen in the mental health context. And one thing that I've argued elsewhere is that just because you have a neurobiological explanation of pain or addiction does not necessarily remove its moral judgments. There's a lot of stigma attached to pain and addiction, and that's not necessarily eliminated by thinking of it in a disease way. Um, you know, Again, calling something a brain disease may legitimize the use of invasive or potentially risky neurobiological treatments at the cost of other less invasive treatments. A neurobiological disease or a brain disease requires a brain intervention. So people may sort of be willing to accept riskier interventions with not perhaps as much benefit than otherwise. And this may come at the expense of broader public health approaches to addressing substance use issues or even chronic pain itself, right? So there's more investigation in very expensive neurotechnologies and not so much in sort of relatively cheaper public health approaches. And as my colleague Wayne Hall talks about, the focus on great and desperate cures. So again, a disproportionate amount of that funding may actually go to some very high risk, again, expensive interventions and treatments that might be only available in major urban centers, and not and so thereby increasing waitlist times and other sort of forms of geographical inequities in the population. Others have talked about the importance of brain disease models actually erasing the social context of substance use, right? So when we understand a brain disease, we don't necessarily understand the development of or the other relevant intersecting factors such as racialized status, gender, ethnicity, age, and poverty, and how that contributes not just to substance use problems, but pain. And we do know there's really strong evidence that populations who are bearing the greatest burdens of chronic pain, so these are, again, people of color, women, tend to receive the least care and also the worst quality of care when they do. So, are there any way to reconcile this? I'm just going to briefly highlight a study that I'm working on with my colleague, Dr. Karen Davis, actually, which Pain BC was a collaborator. So we conducted a survey of people who live with pain across Canada to ask about the potential integration of brain imaging for chronic pain. So this hasn't been published yet, but just some preliminary findings that, we asked the question, if a brain scan could show chronic pain, my healthcare provider would be more likely to believe me. And disproportionately, 67% of the sample, believed that, yes, my healthcare provider would likely believe me, which, suggests a problem that they don't feel necessarily that their healthcare provider believes them, but somehow the representation of a brain image would legitimize their condition. But also, what was concerning for us is not only may it legitimize in the one hand, but it also could stigmatize their condition. So, 189% of 189 participants, or 54, over half the sample, also believe strongly that strongly agreed that the results from brain imaging technology could actually be used to dismiss their self-reports of pain. So this is what might happen if brain imaging demonstrates, so-called evidence of pain or no pain, and that conflicts with the testimony of the person who's in pain, of their subjective self-report. And we always talk about self-report being critical and first and foremost in pain management. But this is a worry of people who are living with pain and others, that their self-report could be dismissed. And in many ways, and as people know, people have their self-reports constantly and their experiences constantly dismissed by healthcare professionals, family, friends, employers, others, and they have a downgrading of their credibility about their experiences. And this is what's called, in ethics and philosophy, an epistemic injustice, or a testimonial injustice, where people are given less credibility than they deserve. And
Dr.
so,
Buchman, sorry.
yep.
You asked for a 5 minute.
Yes, thank you. Yeah, I'm going to wrap up in a moment. Thank you so much. Thank you. So, when we have the contemporary culture of pain management that intersects with groups that are already experiencing a densely woven patterns of stigma and systematic disadvantage, a potential worry here about brain disease framings is that forms of epistemic or disadvantage rather could be intensified in this context. But I think what's really central to this discussion is what's a disease? And we don't have consensus in medicine, healthcare, or philosophy of what actually counts as a disease. So, this is a highly contested concept. And so disease concepts not only shape how people are treated, but how are they expected to behave in certain social contexts. So for example, the sick role. Um, you know, Considering something a disease implies a particular biomedical framing and is particularly powerful. The sociologist Charles Rosenberg said, the social legitimacy of disease presumes its somatic identity. We do know from the literature that when pain is taken less seriously when it does not include a medical explanation, and there are other studies that suggest that participants are more willing to exclude patients who are living with pain from social interactions when no medical explanation of pain exists. So we don't really know what a disease is or what counts or what should count as a disease. So some questions remain. So will a brain disease model of chronic pain reduce stigma? I think it's an open question. Will it compress inequities in treatment aspects and outcomes? Will it improve treatment options, as proponents suggest? And more, I think really importantly, will it reduce suffering? So in summary, the story of addiction as a brain disease, I think, can serve as a cautionary tale for chronic pain and how we think about it. Classifying chronic pain as a disease or a brain disease specifically does have its ethical strengths, but also has some vulnerabilities that we ought to consider. But I think most importantly, and what I want to end with here, and if I can't emphasize enough, is that regardless of whether chronic pain is considered a disease or a brain disease, people in pain should be believed, they should be treated with evidence-based options, and importantly, with compassion. So I'll end there, and thank you all so very much, and happy to take some questions.
Thank you, Dr. Buchman. That was fascinating. A fascinating look. I think we have one question right now, and I'd encourage everybody who does have a question. We have about 10 minutes to put it in the Q&A. First question is, so what's wrong with identifying it simply as a disease, as recommended by the Canadian Task Force, rather than a brain disease? Is there no form of evidence that is acceptable to the healthcare professional community?
So thank you for the question, and I think that's a really important one, and one that I was addressing sort of at the end is that we in the healthcare community there is no accepted criteria for a disease, and a heart is heart disease the same as addiction as a disease or pain, and that was sort of the example that Nora Volkov and Lee talked about initially, making that equation. So it's not just a matter of evidence. I think it's saying, like, do we have enough evidence to suggest from a medical perspective that something is a disease? But conceptually or philosophically, how do we understand what a disease is and disease categories? So I think we're not there yet. But what we do know, and maybe not for chronic pain as of yet, but we do know from addiction being classified in this way, is that there's definitely some ethical strengths, and benefits here, but there's important drawbacks or vulnerabilities that I think, if we are going to make a statement that chronic pain is a disease or chronic pain is a brain disease, and come from very powerful organizations like the Canadian Task Force or the Institute of Medicine, that we have to think about the potential ethical implications of calling something a disease. Because there are benefits and drawbacks, and if the benefits are outweighing the drawbacks, then that can be one thing. But I think we need to be very clear with ourselves. Do we know what we mean, and have we sort of considered the potential implications on the very people who are living with pain on this very classification?
So I wonder, thank you for that. I wonder if the question was kind of around like disease versus brain
Oh,
disease,
okay. So yeah.
right? Because there's like quite clearly a lot of stigma around the brain disease part. But I wonder, I think they were wondering like, well, what about
Just
what if it's
disease
just
in general.
disease? Yeah.
Yeah. Oh, yeah. Sorry if I wasn't clear on that. Um, so I don't know if there's a difference between calling something is a disease versus a brain disease. I mean, maybe maybe there is a difference. I think there could be some really interesting research that looks at that difference, if there's an intuitive difference between this. Or maybe not. Maybe there is something about the brain being particularly vulnerable to disease framings in terms of identity, as I described. But also, we do know from the sort of the history of medicine that just because we medicalize something, whether not necessarily as a brain disease, but call it a disease, does not necessarily alleviate its stigma. So
Mm-hmm.
there's I mean, for example, cancer has had a lot of stigma for many years, and in some cases there still is, although there's been huge strides. Again, similar huge strides in trying to address depression as a disease, in a way. But but then again, there's been some major strides, but also, there's a lot of work to do.
Great, thank you. Um, well, Dr. Karen Davis has just added some thoughts in the chat. Um, uh, oh, uh, her article in the Journal of Pain is Chronic Pain and Disease, Evaluating Pain and Nociception Through Self-Reported Neuroimaging. So that's a great resource.
Hmm.
Thank you, Dr. Davis, appreciate that. Okay, we have some other questions. Oh, hang on. Okay. Okay, can some types of chronic pain be categorized as brain disease while others are not under this framework? And would that be helpful or mitigate some of the potential vulnerabilities?
Thank you for the question. That's a great question too. I think some pain conditions might be considered, more, so to speak, biological than others. What that means. So people might consider arthritis, for example, as more biological than fibromyalgia. I mean, but and so I think and so potentially, so there may be, and I think it's an open question, that some pain conditions or classifications might be considered more to fall in line with the brain disease framework than not. But I do worry though as well, and we do know this from the history, from pain and people's experiences and the history of pain, is that pain historically has been considered, because it's subjective and invisible, sort of quote unquote all in your head, which implies that it's sort of a mental health issue and not real. And so I would worry again, a potential implication here of dividing up certain conditions as being, a brain disease or not, or certain pain conditions or not, that you might again get to some, well, it's not as, conditions that might not be considered as biological could be considered as less real, which we know that's not true. I mean, every pain is real and every pain experiences are real and very, very real for the person. So I worry about that, but I think it's an interesting question.
Yeah, yeah, very interesting. Thank you. Okay, here's an interesting one. How does non-Western medicine frame or consider disease and chronic pain?
Thank you for that question. So I can't comment broadly because non-Western medicine is a lot of different belief systems, a lot of different cultures and histories and meanings and metaphors. So it's I'm very hesitant, and I won't actually sort of clump all of sort of non-Western medicine into one category. Um, but speaking, so again, very generally and very broadly, there are different approaches across the world and throughout history that, and again, have changed over time. Some folks might associate pain with sort of sin and suffering, or again, Judeo-Christian traditions. Other traditions might sort of describe pain or understand pain in terms of animals or animal sounds or feelings or experiences. And again, this is not sort of specific, and this changes over time. I think, again, culture, is not static. And understanding of what pain is or isn't does change over time and throughout history. When I talk about sort of Western approaches, I'm talking about actually also a cultural approach, or I mean, again, not a fixed one either, because in Western cultures, the ideas of pain have changed over time. Um, but just basically the understanding of in a Western sort of cultural biomedical tradition that focuses on objective indicators of pathology and material pathology.
Yeah, thank you.
And actually, I'll just add that different cultures and approaches and systems and belief systems around the world have different ways of understanding pain and treating it, and that really depends on that particular framework that they're operating with.
Yeah, very much so. Yeah. Thank you. Okay, how do you suggest, or maybe do you have any suggestions, moving forward with creating a better definition of chronic pain? If one of the key ethical issues is the repercussions of the brain disease categorization on people who live with pain, what role do you see for those with pain in how their chronic pain is defined?
So can you just repeat the question?
Yeah.
Because I think there's a
I
couple
think
parts.
there's a few in there.
Yeah.
So I think the first one is, do you have any suggestions for moving forward with creating a better definition of chronic pain? And then the second one is, if one of the key ethical issues is the repercussions of the brain disease categorization on people who are living with pain, what role do you see for those with pain in defining what it is? So I guess
Okay, right.
is there a role for people who are living with pain,
Yes.
in saying what they think about that brain disease model?
Absolutely.
Mm-hmm.
And so I guess I'll combine both answers.
Yeah.
So first and foremost, they absolutely, I think people with pain and living with pain should be at the table. And so people should be, part and parcel of research and work. There is recently a new definition of pain that has come out from the International Associated Study of Pain. It's, again, not without controversy. But again, I think this sort of suggests that sort of dynamic nature of pain, that definitions change all the time. And I will say that, so yes, absolutely, to people who live with pain should be part of these discussions, sort of front and center. But also, I think that we think a lot about evidence for pain, and scientific evidence is critical. I'm not questioning that whatsoever. But I think we also need to do conceptual work. I think we also need to do the philosophical work, because we need to understand and conceptualize as a society, what do we mean by pain? This is a really, abstract concept that I don't think we can answer purely with scientific research alone. I think it needs both contributions of science and of philosophy, and of course, people who are living with it, how they understand their lived experiences, and how that, how they create meaning, and how that sort of contributes to an overall conception of pain. Should brain disease framings be part of that? I mean, I don't know. I think it's this is sort of how we're as a society starting to understand or conceptualize chronic pain in this way. But there was that recent IASP definition, I think came out in 2019. And no doubt that will be revised in the future too, based on our increasing understanding.
Great. I just want to draw people's attention. Dr. Davis has just put a number of helpful links in the chat, including the link to to that definition, the IASP definition. Right. So thank you for that. I'll just give people a few minutes to copy those links. We are at 1 o'clock, well, 1:01. So I think we'll have to close the question period now, but that was really interesting discussion, Dr. Buchman. Thank you for that. And thanks to everyone who submitted their questions and engaged on this topic. And it sounds like it's like, more discussions to come.
Definitely. Thank you so much for having me.
Thanks so much. Take care, everyone. See you next time.